Welcome. This is a high-density briefing on the 2026 Joint Consensus Statement from the Korean and Japan Endocrine Societies for Diagnosing Cushing's disease. We'll focus on the core updates for immediate application in your clinical decision-making.
We'll proceed directly through the clinical workflow, starting with the rationale for the consensus, then initial screening, confirmatory testing, localization, and finally, a summary of the most critical practice points. So, first, the rationale. The primary objective of this joint task force was to harmonize the diagnostic guidelines for Cushing's disease between Korea and Japan, specifically to resolve key discrepancies in biochemical testing protocols and their thresholds. Now, why was this necessary? A unified framework is absolutely critical for improving diagnostic precision in East Asian populations. There are population-specific factors, like a potentially higher prevalence of macroadenomas, and possible differences in dexamethasone metabolism that demand regionally specific guidance. Okay, let's move into the diagnostic cascade. Step 1. Biochemical confirmation of cortisol excess. The consensus is firm on this. You need to use at least 2 complementary screening tests to definitively establish hypercortisolism. Right away, you can see the core divergences in first-line screening. The most significant is the overnight dexamethasone suppression test, or ODST. The KES recommends a 1 mg dose with a cutoff over 1.8. The JES, in contrast, uses a 0.5 mg dose with a much higher cutoff of over 5.0. You'll also note important differences in the thresholds for midnight serum cortisol and 24-hour UFC. Let's break down the rationale for these different ODST protocols, because this is key. The KES approach aligns with international guidelines, using that 1.8 cutoff for its well-established 95% sensitivity. The JES protocol, on the other hand, is based on Japanese data and uses a lower 0.5 mg dose specifically to increase sensitivity for milder subclinical disease. The clinical trade-off is clear. KES prioritizes specificity and global standards, while JES prioritizes maximum sensitivity for early detection. Regarding other screening tests, there are 3 main points from the consensus. First, plasma ACTH has pretty limited utility as a primary screen due to significant diagnostic overlap seen in Korean studies. Second, 24-hour UFC levels may actually require ethnicity-specific thresholds, as higher baselines have been noted in Asian patients. And finally, late-night salivary cortisol is endorsed in principle, but its clinical use is limited right now because validated cutoffs haven't been established in either country. All right, so you've confirmed hypercortisolism. The second diagnostic step is all about differentiating Cushing's disease from other causes of ACTH-dependent hypercortisolism, namely ectopic ACTH syndrome. The CRH stimulation test is your go-to for assessing the pituitary response. The protocol itself is standard, 100 micrograms of CRH IV. The crucial piece here is the interpretation. You're looking for an increase of 50% or more in ACTH and a 20% or more increase in cortisol. That response is highly suggestive of a pituitary source, driven by the overexpression of CRH receptor 1 in these tumors. Now, given the increasing global shortage of CRH, we have to talk about alternatives. The desmopressin test is emerging as a critical one. Its diagnostic value comes from the high expression of the arginine vasopressin receptor 1b in corticotroph tumors, a positive response, which is defined by the same criteria, an ACTH jump over 50% and cortisol over 20%, strongly points towards Cushing's disease. For high-dose suppression testing, the consensus recognizes the 8 mg overnight dexamethasone suppression test as a completely valid alternative to the classic and frankly cumbersome 2-day high-dose test. The single-dose 8 mg ODST gives you comparable diagnostic performance. We're talking a sensitivity around 95%, with far superior convenience. Okay, on to the final phase of the diagnostic algorithm, anatomical localization of the ACTH source. This primarily involves imaging and, when required, invasive sampling. Tele-MRI is, of course, the established first-line imaging modality. This is mandatory for all patients once ACTH-dependent Cushing's syndrome has been biochemically confirmed. But here's the critical point. It's not just about ordering an MRI. It's about ordering the right MRI. The task force strongly recommends specific sequences to maximize your yield. Dynamic contrast-enhanced MRI, especially using techniques like spoiled gradient-recalled imaging with thin 1 mm sections, is essential to improve the detection rate of microadenomas that you could otherwise miss. This brings us to a very frequent clinical dilemma.
You have a patient with biochemically confirmed ACTH-dependent hypercortisolism, but their pituitary MRI is negative or equivocal. What's the next definitive step?
The answer is inferior petrosal sinus sampling. The consensus reaffirms IPSS as the indispensable gold standard procedure for this exact scenario. Its entire purpose is to definitively confirm a pituitary origin by demonstrating a significant central to peripheral ACTH gradient.
The interpretation of IPSS is based on strict quantitative criteria. A baseline inferior petrosal sinus to peripheral ACTH ratio greater than 2 or a post-stimulation ratio greater than 3 confirms a pituitary source. And just as importantly, for quality control, you must confirm successful catheter placement with an IPS to peripheral prolactin ratio of greater than 1.8.
Okay, let's summarize all of this. Here are the most critical takeaways for your clinical practice, right from the KES JES consensus. These are the 6 key points. First, always use at least 2 screening tests. Second, your choice between the 1 mg and 0.5 mg ODST should really be guided by your institutional protocol and patient population. Third, you should feel confident adopting the 8 mg ODST for its convenience and efficiency. Fourth, for any MRI negative case, IPSS is mandatory, and you must use prolactin ratios to confirm accurate sampling. Fifth, insist on dynamic contrast enhanced MRI sequences. And finally, a crucial point of caution. Remember that while IPSS confirms a central source, its ability to lateralize the tumor is limited and should not be the sole guide for the surgical approach.
This consensus provides an excellent, harmonized framework, but it also raises the critical forward-looking question. The essential next step will be to generate prospective data from East Asian cohorts to validate these divergent approaches and further refine these diagnostic algorithms with the ultimate goal of optimizing our patient outcomes.